Okay, everybody, welcome and hello from QITalktime. Thanks a million for joining. We have Dr. David Vaughan here today. He's going to be speaking to us on teams, the fundamental building block to improvement. It takes a minute for it sometimes to connect. Sorry, now. There we go. So David, he trained in UCD in 1992. He undertook general paediatric training, and then throughout his career, he's kind of moved into the area of quality improvement. He is the Director for Quality and Patient Safety in the Children's Hospital Group, comprising of 3 Dublin children's hospitals. Previous to that, he was the Clinical Director for Quality and Safety in the state of Qatar, and he was also involved in RCPI as the Director for Leadership and Quality in the Leadership Diploma there, and has also been working with the Department of Health, HSE and RCPI in the area of quality improvement. So today's webinar is interactive as possible. We want people to ask some questions and comments in the chat box function throughout the WebEx. So just click on the bottom icon there and ask any questions or comments throughout the WebEx, and we'll have time at the end to deal with those. There is a phone number for sound. You'll see it there up on the screen if you want to type or listen through the phone. It might be a little bit easier for you. And follow us on Twitter at QITalktime. So without further ado, I'm going to hand over to David, who's going to speak to us on teamwork. Thanks, David.
Thanks, Roisin, and thanks Phil Crowley and QI Division for inviting me to speak. So this is an area that I've become increasingly interested in, because I think it's one of these areas that there's a lot of talk and probably a little less action. And I guess the more I've been involved in quality improvement, it struck me how fundamental effective teams are to everything we try to do, and I think we've almost forgotten that. And just as I was sitting here, I kind of pulled the Bible of improvement, the improvement guide, and I looked in the index under teams, and it was interesting how many entries there were, a total of 0 under teams, which was fascinating. But I think one of the benefits of the formats such as this WebEx is that it brings together like-minded people. And this is a quote that I came across a few months ago, which I think is really relevant and pertinent for the whole quality improvements approach and movements, and that's people who otherwise would have little, if any, interaction with one another suddenly recognize a shared interest and develop pretty profound and lasting friendships. So in the spirit of PDSA, I'm not sure you've done this in previous WebExes, Roisin, but I'm going to ask a few questions and just allow some audience reflection. And what I'd like you to do, if you've got a moment at the end, is to feed back to Roisin whether this was a useful approach or not, so we can decide whether to continue it or scrap it. So the first question is 30 seconds. So where you work, roughly, can you rank these from in order of degree of support that they get where you work? So leadership, data collection, quality improvement, patient-centered care, compliance and regulation, mandatory courses, and teamwork. So not where they get lots of lip service, but do they get fundamental support, resources, training, and so on. So just 30 seconds to do that. So my guess is that teamwork probably ranks down towards the bottom, but if any of you have ranked it towards the top, I'd be really interested in hearing what that looks like. So at the end of this session, which will be about 40, 45 minutes, I hope you'll be able to define a team and the attributes of a high-functioning team, be able to explain why teams are the building blocks of improvement, and with at least one question, begin to analyze your own team. So I'm going to put a little disclaimer here. I think the word quality improvement is abused and misused, and sometimes I think it's the wrong word. in that it can turn people off. And particularly in this context, I think it's important to maybe frame it or describe it differently. So I'd see quality improvement as being the same as continual learning. And perhaps we need to look at teams from that perspective as well. I think we know most of the challenges that are facing us. So demand is increasing, the complexity of what we have to do or expect to do, and our abilities are increasing. There's increasing expectations from patients, from regulators, from providers, from purchasers, from the public. And depending on how you measure it, resources are static or decreasing in many jurisdictions. There's markedly decreasing staff satisfaction, burnout, and problems with staff retention. And the bottom two, I think, are pertinent to this talk. I think there's an inordinate focus on leadership. So we'll send people off in leadership development, and we'll have a leadership academy or faculties of leadership, and leadership is sprouting faster than some things that I probably better not mention on a live WebEx. And also, more importantly, I think learning, if it ever was, is no longer a solo sport. It's more a team sport. So this is taken from a publication just a couple of years old, which is from a air traffic control resource, but it's demonstrating the challenges we're facing across our society in general, not just in healthcare, but the model is as pertinent to healthcare. So we have increasing performance demands, which leads to increasing task complexity. The human in the middle is pretty much static or stable. We often compensate with automation or smart technology or standardization. We have technology driving this innovation and pace of change, and we often just change for change's sake. And that itself is driving the system. So if you look at the constraints within the system and the drivers and the pressures, this is the rate limiting factor. So either the human, the individual human at the center of it can get smarter or work more effectively, or do we take Atul Gawande's advice that men is fallible, but perhaps men are less so? And I think he has a point with that. So thanks to John Fitzsimons for this slide. It demonstrates what Cyril Chandler from London used to say, that medicine used to be simple, ineffective, and relatively safe, and it's now complex, effective, and potentially dangerous. And this is what we're facing. This is a slide taken last week at the ISQA conference in London, shown by Jeff Braithwaite. And on the left, we see the classic hospital org chart, those nice shiny boxes that at a CEO level seem to make sense. We just command and control and send an instruction out, and everything will be fine. And on the right-hand side is the messy reality of life in a hospital, and it is incredibly complex. So the idea that solo leadership or the heroic leadership is the model that's going to save us, if it ever was true, arguably is no longer true. So I think there are three questions to consider. Is teamwork effective? And I'm not even sure that's a question we should be asking, but it's the nature of healthcare that we'll often look for evidence, and I'm going to touch on some of that evidence. I think a fundamental question is, what is the role of leadership versus teamwork? And if we believe that teams are effective and we probably aren't doing as well as we would like to do in developing teams, do we understand what the ideal team model is? What the core competencies of an effective team might be? And what the best methods of training and delivery for team work and team development might be? So I'd like to thank Eilish McAuliffe and Aoife de Boon and their team, the Collective Leadership and Safety Cultures team in UCD for the following slides, which I think kind of brings back my point about the separation of leadership and teamwork. So they quote Michael West a couple of years ago saying that leadership is the most influential factor in shaping culture and is fundamental to health services improvement. And I'm not quite sure that is entirely the case, but I think it's probably 80 to 90% true. But then when you delve into this idea of leadership, and there's so many leadership models out there, and it becomes a little more interesting. So a couple of reviews have found that the impact of shared leadership is more effective in improving the effectiveness of teams and their outcomes, which is defined as a dynamic team phenomenon whereby leadership roles and influence are distributed among team members. And I would argue that a lot of the leadership development programs we have, even if they pay lip service to this, fail to genuinely deliver what they say on the tin that they will deliver. And this is from a forthcoming review by Aoife de Bruin and Eilish and their colleagues, which they make the argument that team development activities and team training are required to develop and enhance collective leadership. And they focus particularly on this idea of shared mental models, working towards common goals and role clarity. So coming back to Claude Dewande, again, making the same point slightly differently, where he says you can't make a recipe for something as complicated as surgery, but you can make a recipe for how to have a team that's prepared for the unexpected. And I think that is the dilemma and the question I would pose. Do we deliberately design and develop our teams in this way? And for the most part, I suspect no. What instead we have is teams that have evolved under different circumstances, and some have evolved to be effective, some have evolved to be quite ineffective. But even the effective teams, my guess is that they could take their performance to substantially higher levels with the appropriate support and training. So another question, so if you can define just 1 minute, either if you're on your own or amongst your group, define a team. What do you understand by a team? Oh, so if you want, you can chop it into the chat box. I've just been advised. Shared goal and clear accountabilities. Working towards a common goal. Okay, so this definition is largely taken from AHRQ in the US, with an addition from me and Red at the bottom. So AHRQ defines a team as 2 or more individuals who interact dynamically, interdependently, and adaptively towards a common valued goal, have specific roles or functions, have a time-limited membership, and they learn and improve over time. And I think that is critical. So I believe that teams are vehicles for both doing, which is not controversial, but as important vehicles for learning, adaptation, improvement, and innovation. So why do we need to do this? This is a couple of papers we published over the last couple of years which show the, and many of you will be aware of these, rate of adverse events and preventable adverse events in this country compared to other countries. So Ireland at the top with the preventable adverse event rate in red. And you can see we're at the upper end of normal. We're about 8% in adult hospitals about 8 years ago. The study was done in patients from 2009. But what is really interesting is that the rates of both preventable and total adverse events are broadly similar around the world. And if you look at similar studies from the Middle East, North Africa, and Asia, we see pretty consistently a 10% adverse event rate, which is quite stunning when you think about it, which suggests to me that the fundamental causes are not the delivery system or the people within it, but the system as designed or not designed as it has evolved. So I think we all agree that we need to improve, but the challenge is how. So do we, as a group of multiple tens and thousands, millions of individuals work uniquely on little projects and hope that it all comes together? Or do we start listening to what the evidence is saying, and Mary Dixon Woods is particularly powerful and vocal on this, that maybe we're taking the wrong approach. And more I'm inclined to agree with her that we are taking somewhat the wrong approach. Isn't it just a question, though, of packaging all these things together, you know, leadership and governance and data and quality improvement skills and patient engagement? And there's no doubt that these are critical, and in some settings they do work, but I'm not sure that they work as effectively as they might do. And this is now leading to another more interesting phenomenon where other stuff is starting to appear, safety tool, resilient healthcare, and joy in work. And what I think is really interesting is that people who talk about systems thinking and the need for us to think in systems still come out of these discrete programs or projects. So it is my contention that things like safety tool, resilient healthcare, or joy in work can be solved most effectively by focusing on teams and developing teams, as opposed to developing separate programs to introduce joy in work or figure out how we do safety too. So another question for 30 to 45 seconds. Thinking back on your career, in the best job, how effective was the team? In the worst job, how effective was the team? And has there ever been a specific focus on strengthening the teams in which you worked? So maybe if you could type a quick answer. Best effective team, worst ineffective team? Okay, so I don't think anything's surprising there. Just looking at the comments, it does appear that the best job, the teams were effective, the worst job, the teams were not effective. And a bit of support for developing and strengthening teams. So nothing surprising. So what's the evidence? So I'd like to focus on four discrete things or pieces. Clinical outcomes, staff burnout, the role of teamwork in implementation, and this is a gray area, the role of teamwork in innovation. This is a paper that was published about 8 years ago. One of the authors was Doug Vaughan, who worked in Kaiser and previously had been in the U.S. Nuclear Submarine Service and is largely responsible, I think, for introducing SBAR into healthcare. And what they looked at was the association between teamwork and adverse outcomes in surgical cases. And they used a validated measure of teamwork, which is on the x-axis. So going from left to right, from 0 is best teamwork, or observable teamwork behaviors as a surrogate of teamwork, to the right with worst teamwork behaviors. And on the y-axis is adverse outcomes, with the best signified by 1 and the worst at the top of the y-axis 6. So you can see a very clear correlation as the teamwork risk index worsens, so as the teamwork becomes worse as you move out the x-axis. There's a very clear correlation between adverse outcomes, both complications, morbidity, and mortality among surgical patients. And this is a very big U.S. study. This is the paper just published yesterday. I just kind of came across it last night in BMJ Quality, looking at the effectiveness of teamwork in robotic urology surgery. And again, using objective measures of team effectiveness, found that anticipation and engagement by the surgical team resulted in about a 10 or 12% shorter surgical time. And recommendation was that training efforts to increase anticipation and team familiarity can improve team efficiency during robotic-assisted surgery. This is a well-known paper from about 6 years ago from the U.S. Kate Chanikoff from Mayo Clinic, who's probably the leading expert in burnout amongst doctors and healthcare staff. Look at the rates of burnout amongst different medical professions in the U.S. And they found that overall, almost 50% of doctors in the U.S. in their samples, about 10,000, suffered burnout, with rates ranging from about 30% amongst dermatologists to almost 2/3 of emergency medicine physicians. So again, confirming what we all know and see every day, burnout and stress and job dissatisfaction are becoming increasingly pressing problems in healthcare. This is just because I'm a pediatrician, I put out some neonatal data. And another big study from 44 neonatal ICUs with burnout ranges ranging from 7 to 55%. And burnout correlated with poor teamwork climate and poor safety climate. And we know that these also correlate with poor outcomes. A very big study from the US has found that poor teamwork climate has correlated with poor surgical outcomes and also high central line infection rates. So can we do anything about it? This is another very big study from the VA system where they looked at about almost 100 hospitals and followed the reduction in operative mortality, surgical mortality, following the implementation of a structured team training program, and found that there was both a substantial reduction in the intervention arm of 50% versus the control arm in mortality, and that there was a dose-response relationship. In other words, the more teamwork training you got, the better the effect in terms of outcomes. So I've covered briefly the link between teamwork and outcomes and teamwork and burnout. Where does that nexus lie with teamwork and quality improvement and implementation? These are non-medical, non-healthcare studies, but I don't think, based on my observations, those of others, that healthcare is any different. 80% of Six Sigma implementations fail, and bear in mind that that's not unusual for any quality improvement methodology. But depending on who you read, between 70 and 95% of all quality improvement initiatives fail across all organizations. So of that 8% that fail, it's felt that 60% fail due to poor team dynamics. Other studies have found 14 reasons why teams fail in quality improvement, and I've referenced both those papers and publications at the bottom of the slide. This is another interesting paper from Amy Edmondson from the Harvard Business School, who's done a lot of work on teamwork in healthcare, where they examined a number of cardiology units introducing a new intervention across the US. And they looked at the differences between the units that succeeded and the units that failed. And they've taken a sub-selection of 4 of those hospitals that they looked at. And Hospital 1 and 2, they successfully implemented. Hospital 3 and 4, they failed or abandoned. And it's quite striking the differences between the characteristics between the ones who succeeded and failed. The ones who succeeded, you had a senior surgeon who communicated a need for help from his team, or a junior surgeon emphasized the critical role of team members. In contrast, those who failed, you had that stereotypical lone surgeon who wanted things to work his way or her way, and really didn't involve the team. The psychological safety was really interesting as well. So in the teams that succeeded, staff felt free in contributing and speaking up, whereas those that failed, there was a lack of psychological safety. People were afraid to speak out. And looking at the common goal that bound people together, again, striking. Those that succeeded, the intention was to help patients or to help the team. Those that failed were for more arguably egotistical or less altruistic reasons. So I believe that perhaps we've been looking at healthcare improvement slightly in the wrong way. I think I'd divide it into 2 broad categories. A system bundle, so that could be things like early warning system or VTE prophylaxis, or even at a hospital or ward or unit level, the things that we think need to be put in place. And we know that putting them in place is hard enough, but improving them becomes even harder. And I think that's where that high-performance team comes in, that nexus between the two, that intersection is where we get reliable implementation, continued improvement, communication, and learning. So that leads to the question of what is that high-performance team? What are the skills and characteristics, behaviors, and attitudes they need? Again, coming back to HRQ, they divide teams into 3 categories. They talk about the core team, which is the patient or the team that provides direct patient care, whether it's inpatient, outpatient, ambulatory, theater, ICU, whatever, accepting that members of that team will change and flux. Then they talk about a contingency team, and that team is most often best thought as a cardiac arrest team or a rapid response team. And then the third team that is critical to care is that coordinating team. So that's the administration secretarial support, often health and social care professionals, cleaning staff, portering staff, all those. So if we believe that none of us is perfect, no, some of us do, but a team may be perfect. How do we get there? What I've broken down on this table is the various domains of that we feel are important in improving care. And on the right-hand side, what I feel are the correlations with teamwork. And what I've tried to do is make that link explicit, that these cannot be looked at in isolation of teamwork and will fail, arguably, in the absence of teamwork or in the presence of a poorly performing team. So leadership, I think we'd all recognize is critical, but what we less often think of is leadership of what? This whole idea of leader followers. We need someone to follow the leader. So by definition, we need a team. If we're not working effectively as a team, I find it hard to believe that we can focus on patients because we're too busy focusing on other stuff outside of the team. We may have the best data in the world, but if we don't work effectively as a team, it's going to be hard to both analyze and constructively criticize and figure out how we're going to make improvements based on that. Using improving methods or tools, whatever they are, again, if we don't work effectively as a team, if we don't understand our roles and responsibilities, who's going to do what, who's going to collect the data, who's going to implement. If we're not a standard team, I don't believe that we can learn effectively as a team. I don't believe that we can standardize if we don't work as a team, if we can't agree on common goals. And we can't support one another if we don't work as a team. This is another paper from Amy Evanson where she has broken down the management approach. So the organizing to execute is what she calls it, which is the 20th century manufacturing at scale model, which has been the approach that has been taken to healthcare as well. And what she distinguishes from organizing to learn, which in complex service industries is probably the way we need to be leaning, accepting that the organizing to execute model is the appropriate way in some respects and some activities in healthcare. So for measuring performance, when we organize to execute, the question is, did you do it right? When we organize to learn, the question is, did we learn? Structuring work, organizing to execute, we separate expertise, very clear delineation of roles and responsibilities, and little flux and movement between them. Organizing to learn, we accept the ambiguities and constant change, and we try to integrate that expertise. Organizing to execute, we try to minimize employee discretion. Organizing to learn, we seek a multiplicity of options from everyone. Empowering people, when we organize to execute, we tend to minimize the degree of empowerment we grant them. When we organize to learn, we encourage them to create their own approach. This is an interesting paper in the New England Journal of Catalyst just earlier this year, where they took work done by Google. And Google, in their tried and trusted data analytical way, looked at what made effective teams in Google. And they found huge differences in the performance of teams. And when they have a structured tool, which is not available, unfortunately, but they analyzed the aspects of their teams and came down with 5 criteria that distinguished high-performing teams from less high-performing. And the most important factor was psychological safety. So team members feel safe to take risks and be vulnerable in front of each other. There's dependability. Can I rely on my colleagues to do things properly and promptly when they need to be done? The third is structure and clarity. Do we each understand our roles, our plans, and our goals? The fourth was meaning that this work was meaningful personally to each team member. And the fifth was, did the team members believe that their work made an impact? So I think this is an interesting one when we look at the amount of form filling that we have to do in healthcare now, and that's only going to increase. And I think that is a big factor in the burnout and disillusion that we're seeing in healthcare. This is another way to look at teams. It's taken from HRQ again, which is a great resource, and I've modified it slightly, but they break it down into four 4 major attributes, which is leadership, situational awareness, communication, and mutual support. And I've added a couple of things beneath that, getting back to this whole idea of teams as learning mechanisms, so applying learning and after action reviews, debriefing. I think the role of simulation we're only beginning to touch on as we develop teams in non-cardiac arrest or non-technical skills interventions. I think the role of coaching we've hardly begun to scratch in healthcare. Negotiation, conflict resolution, again, I think are critical skills to advancing in healthcare. And those, I believe, are many of the key attributes that we need to be developing in teams deliberately and purposefully. So even if we get perfect teams, and that's going to take a lot of work, does that mean that we'll get the end of our challenge? And I don't think so, because we have a problem in that even if all these teams are perfect, there's that interdependency between the teams of teams. And this is a book that I'm not a big fan of business books or leadership books, but this is one that is really interesting, that I have enjoyed, not because it gives answers, but I think it raises a lot of questions, and largely based on Stan McChrystal, who was a U.S. Special Forces general in Afghanistan and Iraq, and his experience in fighting al-Qaeda in Iraq, and how the U.S. military, high functioning and hierarchical as it was, really struggled to adapt to a different enemy. So it wasn't the Russian army that they'd been built up over 30 years to fight. This was a radically different, radically changing, dynamic, unpredictable enemy. And the book describes how he basically reconstructed the org structure, the communications, and how individuals and teams work with one another to overcome this challenge. And if I had to summarize the lesson that he laid out, really it was about breaking down hierarchy, sharing information widely at all levels, and trusting people at the front line. So I think there is something there that we will need to learn in healthcare, but what it looks like, I'm not quite sure. I think it'll be facilitated by improved IT systems, with the caveat that many of the IT systems that we're introducing around the world probably are not fit for purpose for this kind of rapid transmission of information. So I'd like to leave with a few questions for the audience in terms of how you might self-assess your own team. So I think the first question that we should always ask is, what is our shared purpose? And how do we agree it, and do we all understand it? And it's striking that how often, how rarely we do that. I had a session with some NPHDs about a month ago, and there was about 5 at the table, and I asked a question, do you where you work go in, and is there a shared goal other than, well, that's the patient out and prescriptions written, and one doctor, she just looked at me, I thought blankly, and didn't say anything, and she stayed silent for about 10 minutes, and the conversation continued. And she suddenly said, that's the most profound question I've ever been asked. And I don't think it's that profound, but I thought it was striking how often we do that. We just go almost mindlessly into work and just see patients or write prescriptions or dictate letters without figuring out, do we have a higher purpose here? Do we have a shared goal that we're working against or towards? The second question is, how do we generate psychological safety? And this is really, really difficult. I think it stems from self-awareness in the first instance, and that is difficult to maintain in busy, dynamic, stressful environments. Do we all understand our respective roles? Again, that's a real challenge. A good friend of mine who's thinking I probably admire more than anyone in the country, as we were discussing this the weekend, he asked me, I said, I can think of 10 teams at least that I work with where I work. So, where do you start? And they're all chopping and changing, and they change every 6 months, and the locums coming in. Where do you start? And that's a really interesting question. I think where you start is either the area of biggest opportunity are the biggest risk. But start small and figure out what works and what doesn't work. The next question is, as a team, how do we communicate and maintain situational awareness? And in my experience is we don't do that except in crisis, and then it doesn't work terribly well. And how do we constantly adjust our work as our goal and the work and work environment changes? And lastly, how do we support one another? Okay, so there are some suggested links on Twitter that you might follow if you're interested in this. And I've put them up on Twitter. It should tweet in about 20 minutes. I'm going to also plug the HSC Improvement Skills, HSC QID Improvement Skills Guide, which is to be launched tomorrow, lunchtime.
Tomorrow, yes.
And it will be going up on QI Improvement. Anyway, I tweeted the link as well. Okay, so I hope people enjoy that.
Thank you very much, David. Philip Crowley here. Yeah, I've been listening in the background here, and it's great, I think, to emphasize the importance of teamwork. I think we all know it inherently. We've experienced good teams and bad teams. You can see that from some of the responses. But it's good also to see, I think, that there's an evidence base behind it as well that really reinforces the message. I think you drew out an important link as well between teamwork and leadership, the style of leadership that generates teamwork, and other styles of leadership that simply don't. And I think they're importantly linked. There's a few very interesting questions here, and we'll see if we have time to cover as many of them as possible. One is how important, in terms of creating teams, is learning together in teams, or to create teams, and is experiential learning more important, or have you come across some formal education in effective teamwork? Maybe the simulation labs you've already referred to. I mean, what's the best way of we talk about, have we had training in teamwork? What kind of models of training?
So I think experiential. I think the role of simulation is critical. So Carl Horsley, who is an intensivist in Auckland, probably is one of the best practical applications of safety tools that I've come across. And he started with the simulation approach and then evolved into that. I think the benefits of those, either simulation or experiential workplace, is that really breaks down the psychological safety barriers. You see very quickly if you have that safety or not. Mm-hmm. And if you don't, you're probably wasting your time. Yeah. And if you do, and I think you can, those are the only environments in which you can learn. You can't learn from a book.
Sure. Yeah, absolutely. And tell me, another question which I think is kind of linked as well. How do you configure or construct an effective team, or are we talking really about groups of people who we want to create a team out of who already exist theoretically in a team? How about constructing a team?
So
how do would you involve patients in that?
I think you can construct a team, but I think just, the constraints of the system we work in, that's hard. I suppose I got interested in this just observing people with a bit of money and said, oh, let's do some human factors training. And you couldn't knock that, so they get people who've done aviation human factors and get a group of people in a room. And it gets back to that quote from Robert Pirsig, Zen, the Art of Motorcycle Maintenance. There's so much talk about systems and so little understanding. The idea that you can bring random people into a room, talk about teamwork, and then send them out, and I'm not convinced it works. So I think you have to make a deliberate decision. Is this important? Is this critically important? And then I think it's a co-design process. I think the team with the patient on the operating table probably doesn't have that patient focus as much as the outpatient team or the inpatient team, with the geriatric patient. But again, it comes back to my contention that I think it's the fundamental bedrock. Let's get the team together and say, well, what does that patient-centered care look like? How do we deliver it?
Yeah, I've certainly been a member of some very dysfunctional teams, non-teams really, and some very effective ones. So another interesting question here is, we work in an environment with a lot of flux and change. Either in an acute setting where, different people come in to see the patients at different times, not always kind of actually physically working together a lot of the time. Then even more so, I guess, in the community where people are kind of coming into people's homes at different times as well. And they should be a team. They're only really notionally a team because of physical and process challenges. How do you think you could overcome some of that? I mean, that's quite challenging, isn't it?
So I think again it comes back to, let's pull that up there. So who's in charge? What's our goal? What are we aiming for? How do we maintain situational awareness and communicate? So people may be aware of the IPAS study, which was published in the New England Journal about 3 years ago, which to me is one of the most astounding studies ever published, in that it's a cheap intervention, it's simple but it's hard, and it reduced adverse outcomes by 25% across 10 children's hospitals. So taking a structured approach to communication and maintaining situational awareness clearly works. I think it's harder in those geographically spread locations, but I think it's doable. We can certainly do better than we currently do.
Yes, I think we certainly can. There's also, I think, there's another kind of question or reflection here that we tend to kind of think in terms of improvement of kind of scientific approaches like Lean and Six Sigma, the IHI model for improvement. Do you think at times we're maybe failing to appreciate the potential and importance of frontline teams working things out for themselves?
I think so, and I think that's what the whole safety 2 paradigm is about, even though I don't think they express it right. So people are looking at safety 2 as a set of things to do, and more I think safety 2, or resilient healthcare, is an emergent property of high-functioning teams. That these are smart people. They can figure it out. And we see that. I mean, we see it every day. The dysfunctional teams rant and rave and scream. Yeah. And the highly functional teams fix things.
Yeah. And another interesting question, and we do obviously operate in we are competitive type people. I think who go into healthcare, we operate in a very competitive environment. There's obviously going to be competition between teams, and particularly in some organizations anyway. How do you kind of deal with that, both to gain, I suppose, some of the benefits from competition and driving people on to better performance, but also ensuring that we collaborate across teams and have the wider team?
I think there's a couple of ways. I think it's having that shared goal, and that we all agree that whatever that shared goal is, and that open, honest communication and transparency, but that team of teams approach, which is effectively what he did was he broke down the silos of information that service 1 kept information from service 2, and the general and the private stood in the same room and sold the same information. And the pushback was, well, this is confidential information. Why should the private see it? That it makes no difference. Everyone's opinion is valuable.
And why, this is an interesting question, and maybe one for all of us in some ways, but why do you think, in this instance, that there's so little or very almost no emphasis on teamwork in Irish healthcare? I mean, it's not talked about much, as you say. You highlighted the work on the Leadership Academy, which I think is a valuable thing. But maybe teamwork is getting lost in all of that.
I think there's a couple of reasons. I think we're individualistic in healthcare. It's not just this country. I think I think there is this myth of leadership. We want to be the hero, and I think the evidence base is still poor. I don't think we know exactly how it works. One thing I'd like to do is kind of throw Lean or Six Sigma or something into one setting, and then take a more structured approach around teams, and then build the tools. So my own view is you get the team right, you can throw anything at them, and they'll run with it. It'd be a fascinating study. I'm not sure it's ever been done.
Well, I look forward to the results from that one, all right. Another good question here. Building teams and any of this kind of developmental work takes time, I guess. And we all work in stressed work environments where we're kind of chasing around, and quite a reactive environment in which we all really work. How do you think you can create an environment in which teamwork can flourish in that type of environment?
It's hard. It's really hard. But I think one thing that we don't do well is say, well, what are the 1 or 2 things that we want to do this year, and that as a team achieve it, and even that success. So why do people run ultramarathons? Not because it's pleasant. They want to achieve something. That's what we do as humans, and that's That's what people want to do as part of a team. But I don't think we're good enough at saying, getting back to what that doctor said to me. She'd never gone in and thought about what's the bigger purpose.
Yeah.
So if the bigger purpose was we're going to get to 50% VT prophylaxis, that's something that they're all agreed and can work together collectively. Whether they succeed or fail, it's less important, I think.
Yeah, Rob, one of our listeners, has kind of highlighted some of the simple things, I guess, we can do in just creating time to spend a little bit of time with each other and talk and get to know each other, have a cup of tea. How important do you think those kind of simple things are?
So that mutual support. So there's a quote I put up a couple of weeks ago from Maya Angelou. People will forget what you say, people forget what you think, but people will never forget how you made them feel. And I think that mutual support, that cup of tea is critical. That flower on the desk or roll on the desk, people will never forget that.
And then finally, the last kind of comment is from Una talking about kind of the boundaries and suggesting maybe that less teamwork maybe is our reality in healthcare, and we need to find a way of adapting to that or changing that, I guess. I mean, I think really the purpose of what you've been talking to us about today, and something I completely agree with, is we need to fight back and create an environment in which teams can flourish, and we need to speak up for this, really.
So I think part of the problem is that the older generation grew up trained in the 70s, 80s. So Atul Gawande says, I remember seeing similar figures from here. In the 70s, the average patient was looked after by 2.5 caregivers, so a doctor, a nurse, and kind of half another. And in the 2000s, it's about 25. So that is the way things are going. So we either accept that, that complexity is increasing exponentially, and smart, hardworking individuals can no longer handle that, and teams are the way to go, or come up with another solution. I'm not sure what the other solution is.
Yeah, and there's just one last question about, I've dealt with a question around competition, yeah. The only other question was really whether, you talked a little bit about complexity science and that. Is there a particular thing that you recommend to people to read just to kind of understand better, I suppose, the science around the complexity of the environments in which we work in?
I just can't think of one off the top of my head. So ask Rob Cunning, at Rob Cunning on Twitter, or Carl Horsley is a very good repository of wisdom. So we can put that, I'll tweet that question in a few minutes.
Okay.
But again, I think the problem is we're linear thinkers, and we're looking for linear solutions, even when we say we don't. And the complexity science literature says that there's no linear solution. And I think that is the tension. We'll need to learn to let go and trust people on the front line.
Yeah, absolutely. Couldn't agree with that more. Look, I think that's a very good point to finish on. Let me hand it another.
No, you're all
So really what remains for me to do is really to thank you very much indeed, David, for being with us today, and hopefully you'll come back and we'll have some follow-up and develop some of the ideas we've been developing here today. Thank you very much indeed. We have another WebEx on October the 24th. Professor Brendan McCormick on person and family engagement. Brendan is doing some work with us on person-centered care, very high-quality work on really changing processes of care. Very in-depth practice change. So I think that'll be a very good session as well, so I recommend it to you all. I'd like to thank Roisin very much for running today so effectively, as always, and for you all for participating. Thank you all very much indeed.
Thanks, Rob. Thanks, Roisin.
Thank you.